Hello everybody, and a very warm welcome. My name is Ainslie Course. I very proudly sit on the board of the Clusterbusters Board of Directors, and I'm coming to you today from Glasgow in Scotland. I'm going to introduce our speaker, but I'm going to tell you a little bit about him first of all. Dr. Brian McGeeney received his medical degree from University College Dublin, Ireland, before completing a neurology residency at Boston University and Boston Medical Centre. He obtained boards in neurology with added board qualification in pain medicine. He was assistant to the Boston University Neurology Residency Director and assistant professor of neurology, actively involved in the education of residents and students. Recently, Dr. McGeeney moved to J.R. Graham Headache Centre, Division of Headache Medicine, Department of Neurology at Brigham and Women's Hospital in Boston, Massachusetts, Harvard Medical School. Dr. McGeeney has lectured widely and published on topics involving headache medicine and pain. Brian McGeeney is known in the Clusterbusters community as Super Neuro. A nickname I'm not quite sure if he knows he's achieved, but he has. He very willingly gives his time and expertise to our organisation without question, of which we're incredibly grateful. He's also a very, very respected member of our Clusterbusters Medical Advisory Board, and he's really just a great all-round guy. So Brian is going to present to you today Cluster Update and Navigating Treatments. And he's also happy to take questions going through, but we'll try and sort of do them in little clusters, pun intended. And on that note, I'll hand you over to Dr. Brian McGeeney. Thank you, Brian.
Wonderful. Thanks very much, Ainslie. And thank you to the board for continuing to have faith in me and allow me to address the conference. I love every one of them. I think this is conference number 11 or 12 now for me. So it really is an honor and a privilege. And the reason I come to these meetings primarily also is my education and to understand what you guys are going through to help folks that I see. And I have an awful lot of leeway in the talk, and I really encourage you to ask questions, because normally I would be roving with a mic, as some of you know from previous meetings. And I start off like I started off last year, but just to say that it's good to see that some cluster headache is in the media now, and there are some stories rather than nothing. There was a lot of years where there really wasn't anything. And I showed you this last year on a website where unfortunately they use the term cluster migraine, which really should be avoided. It's a nonsense term. It's an admission of ignorance, because cluster headache is not migraine. Migraine is not cluster headache, and they should be easily separated. Patients can easily separate it, so the practitioner should. And when I messaged the owners of this website, they immediately took that down. And that's what I said 1 year ago exactly at this meeting. However, when I checked that recently, it was up again, no change. So I'm fuming about it and will contact this person. So be warned, beware of the term cluster migraine. And when physicians use it, they usually use it because they're not that familiar with cluster, and the patient may have some they identify features of both, but really it's either one or the other, and they're unable to make that separation. Or they may have clearly cluster, but if they don't come in your so-called typical demographic, middle-aged male, they may use the term cluster migraine for younger women, for instance. But really beware of people who use, for practitioners, beware of the professionals who use that term. It is a nonsense term. And I played this video last year, and if you can't hear it, let me know. And it's good to see, at least in some manner or form, cluster headache in the arts.
No, seriously, I can't think of anything worse.
Father of 4 in Cincinnati,
early onset Alzheimer's. Or this lady who suffers from cluster headaches. And if Renegade doesn't get her to Seattle to be a zombie, she is moving to Oregon to go out on her own terms.
Well, that was a bit morbid. I'm
No.
sorry, but at least it gets in there. And what about this one? It's an old favorite. Some folks have seen it before.
Oh, almost forgot. I need to give a 16-year-old magic mushrooms to treat a cluster headache. Is that cool?
No problem.
Mushrooms have psilocybins that work on cluster headaches.
Pain's getting worse. Need shrooms now.
Well, at least it gets into the media anyway. We use the term, the cluster headache is probably the most simple name of other proposed names for the same disorder. And I put them up on the screen. My favorite, erythroprosopalgia. I have to be very, very alert to pronounce that properly. These were all the proposed names, and the last one kind of stuck, probably because it was the most simple. Dr. Kunkel, thank you very much. And the term cluster refers to the cluster of weeks where the patient is active for the 80 or 90% of people who are episodic. And that's why he used the term cluster headache. All right. And to bring everybody on board, we're talking about a uniformly severe, strictly one-sided, strictly short-lived headache syndrome, and short-lived about an hour to maybe 20, 30 minutes if you're lucky. The best estimate on gender breakdown is probably about 3 to 1 men to women. It was in the older literature much more male-dominated, probably because of lack of ascertainment of women with cluster. They were erroneously told they had migraine. Autonomic accompaniments. Autonomic means the tearing or the like bloodshot eye and the running nostril, so on the one side, or blocked nostril on that side in particular. You can get other things like a droopy eyelid and even pupil changes. But those features, some of them are present in over 90% of people, which helps make the diagnosis. Migraine often has a little bit of that on both sides, but strictly one side, and you're really narrowing down what could be going on. And typically it attacks anywhere from 2 or 3 to 5, 6, 7, 8 or thereabouts. And for most people, episodic, meaning when it switches off, you have months of relief. If you don't have more than 3 months of continuous relief in the last 12 months, you have cluster headache. And the unspoken concern among people with episodic is, are they going to go chronic? Most people never go chronic, but nevertheless. And you can also start chronic, unfortunately. And yes, there is an exit. People do stop their chronic even after decades. And as Bob mentioned earlier, there are a lot of people who start in childhood as minors. And it's a bit of a disaster with respect to making a diagnosis, unfortunately. And I think I know why, is the pediatricians rely on pediatric neurologists to make that diagnosis, or to educate them, at least. But the pediatric neurologists are not making the diagnosis, or are not so familiar, unfortunately. So what happens is somebody with clear cluster, but in childhood, doesn't get the diagnosis, as some of us know to our cost. And we're talking about over 20% of people and minors when they develop it first. So this is a slide of age of onset, the onset age. And really the onset can be all the way up to the 50s and even 60s. And before age 14, about 6.5%, which is not tiny. Now you can have a cluster period, that is again, the cluster of weeks or months when you're liable to repeated attacks at any time. But it tends to be a bit more common in the spring and fall. So there is a predilection, but it's not strict. One sure thing about cluster is that it can change in the individual with time. All right. So what you need to know, or at least in passing, is that cluster headache is the most common element of a group of disorders. Paroxysmal hemicrania, the Sunk-Suna group, and even hemicrania continua has been lumped into this group by the headache medicine professional community, know that I will only tell you that the paroxysmal hemicrania is like cluster headache features, except it's much shorter and more frequent, and also more women than men. So you might be 5 to 15 minutes and more frequent attacks. And it's also much less common. So if you're not sure whether somebody has paroxysmal hemicrania or cluster, the length of time alone, or excuse me, the fact that is, without knowing anything more, cluster headache is 5 or 10 times more common than paroxysmal hemicrania. Sunk suna is also a rare disorder. Think of cluster lasting seconds or half a minute, and then repeated. That's sancta suna. The difference being whether you get conjunctival, so it's eye puffiness and tearing. And hemicrania is actually a continuous headache syndrome, although the intensity varies. It's in there for various reasons that I won't go into unless somebody asks, but you need to know just a little bit. And despite our increasing knowledge over the decades, really the most well-known trigger is alcohol. And I know others, some folks have issues with bright light, sunlight, and even altitude, elevation over 10,000 feet may trigger an event, but not much in the way of triggers as opposed to migraine, which has many, many. All right. So when you first develop cluster, this is the list, partial list of other diagnoses in the literature that may mimic cluster. Now, this is really for newer diagnoses. So if you've had what appears to be cluster for years and years and years, it's not going to be one of these. But if you've developed it in the last few weeks or months, which is why you all need a head scan at least once. Now, if you've had cluster for 10 years, you don't need a scan if you've never had it. But if, again, new presentations, one must think about this. And again, I welcome questions. There are many problems we have treating. And first is really making the diagnosis and late diagnosis. There's I think maybe our guidance, as professionals, when we guide patients, it may not be the best. And I'm sure plenty of you have examples of that. And lots of the treatments that we use can often have little or no help. But bear in mind that there's a great variation from person to person in their responsiveness. We heard how in one patient earlier, Emgality didn't work so well for them, but in others, it's helpful. And so you must keep an open mind. And because of this maybe lack of good guidance and lack of help, a lot of patients, what I term decouple from the medical community. And kind of we need to get them back in, but we need to do a better job in order to facilitate that. As an example of the problem of late diagnosis, I often use Tom, and I think Tom is at this meeting. Thank you for allowing me mention you and use your picture, who developed intermittent headaches, told migraine in 1967, and they continued without a significant break, and he only got the correct diagnosis in 2015. That's a good few number of years to have the wrong diagnosis. Nevertheless, Tom managed to work and even volunteers time, and not just for the cluster community, for the multiple sclerosis community as well. I know he donates his time. On the slide on the right there, photos from previous meetings. On the top left is Portland in 2010, where the oxygen canisters. So if you come to a physical meeting, rest assured there will be oxygen there. And top middle, we have an oxygen training session, of course. Part of the problem with making the diagnosis is a number of big problems. And one of them is, to the practitioner, it may not clearly be around the eye and temple on one side. There's also a lot of referred pain to the midface, to the jaw, teeth, nasal sinuses, i.e. midface, neck, A lot of you will involve the neck or back of head. So you can see how complicated that can be. I think that has a number of reasons. But the main pain problem generally is still here, is what we term the V1 area, the upper third of face. The bottom of the slide, I talk about a study of over 1,100 patients and looking at the delays in diagnosis. Initially, they got the diagnosis, only a fifth of them got the correct diagnosis initially. And a massive 16% had an unnecessary dental extraction. Don't you love that? And 12% had an ENT operation. So if the sinus is there, they're worth reaming out or doing something with, well, before the proper diagnosis, unfortunately. So there is a question.
Yes, Brian. Would you take that question now, please?
Yes. Yes.
Great. Thank you. We actually have two questions. The first one being, could you give some suggestions on how to get either a SUNCT or SUNA diagnosis from a neurologist? I just don't think they understand it. So would you like to take that question first, and then I'll pose the next one?
Well, to a neurologist, one would hope that it's not that difficult for them. The first thing is you have to be able to articulate the problem well. Part of the problem with late diagnosis is not being detailed in the history. And this is not blaming the patient, but it's up to the doctor to coax a detailed history out. So, for instance, with cluster, when the cluster attack ends, you may be left with shadow sensations, which are in no way that uncomfortable, but are still there. And if you refer to that as the pain as well, you may not present a history of discrete short-lived. So the intense attack is really short-lived, an hour, 30 minutes. And the same with SUNCT, describing that there are episodes, paroxysms that last 30 seconds, a minute, 2 minutes, 3 minutes, and often associated with tearing. And that intensity dramatically falls then, and then you have another bout. Describing it, I think part is describing the detailed element. And there really is, and over the passage of time, there really is nothing else that it could be early on, or an early on is a wide differential. So that's why you need a head scan. But the best I can do is, I do have a slide on how to talk to physicians. But if you feel you have SUNCT SUNA, you might do is get some literature on it and present them with some literature and said, I think I have this. What do you think? Ask them. But maybe you've already gone through that, or maybe the person who was asked the question has already gone through that. I can take further questions at the end or at the Q&A session, but being descriptive, put your description down in a succinct manner as possible. Take some photos. If the eye gets teary and the other doesn't, take some good nearly everybody has a camera phone now, and make it descriptive. All right, Ainslie, and we have.
That's great. I have one more question. Would you like to take that now?
Sure.
Thank you. Someone would like to know, do you have any theories for the exact mechanism that makes alcohol a trigger for the majority of cluster heads?
Yeah, the short answer is we don't know. The longer answer is, alcohol is a neurotoxin that's marketed as a beverage. So it's a toxin. So it's widespread disruption of the brain everywhere. It's not that potent, which is why you need to take glasses of it. Whereas with potent poisons, even a small amount that you can barely see would kill you. So the message is it causes such widespread disruption. And this happens to be the summation result. So we really don't know where it's acting that it's most irritating, because it has a very widespread actions, unfortunately. And that's not a great answer, but that's the best I can do.
That's great. Thank you, Brian. We have one other question. Would you like to take it just now, please? Thank
Yep.
you.
Yep.
So, hi, Dr. Brian. What are your thoughts on high doses of verapamil, as in 480 milligrams?
Good question. I'm going to come to that, and remind me if I don't address that in the next few minutes, but I will come to that.
That's great.
That is important. This picture on the left of the slide I took over 10 years ago of a gentleman attending one of the meetings, and you can see the oxygen and the tusk through his face. And he also drew, I think, some missing teeth here. And I take it you can see my cursor when I move my cursor on the screen.
Yes, I can, Brian. Yes.
Good. All right. I know we're going to have a session on talking about early onset and pediatric onset, but 3 of the cluster member board members kindly participated in an event a couple of years ago now at a professional headache medicine meeting, and it was the best part of the meeting. I'm biased, but it was still the best. Got to educate professionals, physicians, nurses on this whole entity, and Andrew was able to, hopefully you don't mind, Andrew, if I play your piece, but just as given an example.
All right. I was 12 years old sitting in 8th grade algebra class, the first time that I ever felt it. Although I had no idea what it was at the time, I could feel the creeping aura over my shoulders. My left temple began to pulsate intensely, accompanied by a searing pain in the left side of my head, face, and my gums. Having never experienced a normal headache before this, I assumed it was just one of those regular headaches people always talked about, right? Unfortunately, that was just the beginning for me. After a few more attacks, my mother began to realize this wasn't just a one-time thing and something was really becoming very wrong. We went to my pediatric doctor, who immediately dismissed that what I was experiencing was legitimate. I was a young kid trying to skip school and responsibility. So we tried the OTC meds, the Excedrin migraine, tension headache, sinus headache, even that roll-on stick that's supposed to cure your headaches. All the variables. And after a few weeks of no success and a downward slippery slope, she realized this was not the solution to our problem. Considering that it could be something similar to, but not head pain, I was taken to an ENT who diagnosed me with a deviated septum as the cause of my pain and booked me for surgery. After a complete waste of time, pain, and money, the thought occurred that my wisdom teeth could be coming in. I was taken to an oral surgeon at the age of 13 who said while my wisdom teeth were not coming in and I was probably a couple of years away, he would extract. 4 wisdom teeth extracted with no pain relief. And let me tell you, that was a cakewalk compared to what was coming. Once we realized my issue was not going to be solved as quickly as it came, my mother decided it was time to seek more professional help. My next stop was at a psychiatrist's office. After asking me some basic questions about my life and my background and why I was there visiting that day, he decided that the pain in my head was exactly that. It was all in my head. It was amazing. It took him all of 30 minutes of knowing me. See, I was bullied pretty bad as a kid, like many children are. I didn't have the traditional upbringing. And because of these stressors, he proceeded to diagnose me with somatoform disorder, meaning that the mental disorders or the mental stressors being experienced in my life were so significant that they were manifesting themselves in physical ways. Suicide headaches was my case. His recommendation to my mother, tell him to just make it go away. He has the power to make it go away. Don't give in to him when he's screaming. Sorry. Bless my mother for doing what she would do, taking the advice of a professional before consulting the internet. We took it as fact and we went down that path. Weeks passed, 3 to 7 attacks a day in bed or on the couch, store, school. And my mom the whole time would just say, just make it go away. It was really hard for her to say, as it was for me to hear. The mental torture experienced on top of the...
Well, Andrew, I hope you forgive me for playing that, but it has helped an awful lot of professionals to understand the problem. Now, with respect to treatment options, we're still as much as we've progressed in the last few years, there's an awful lot of room to improve. We still have very limited evidence-based medicine from which to guide therapies. We need more options, in particular for chronic cluster, which is a big need. And there was a lack of research investment for many, many years, unfortunately, throughout all of headache medicine for various unpalatable reasons that has been partially addressed now. And because of this, again, I use the term decoupled from physician care, patients may end up often on oxygen and sumatriptan injection and really not be followed actively by anybody. For a long time, all we had approved by the FDA was injectable sumatriptan, and that was just to abort an attack. We now have some more approvals, and we need a lot more. Even verapamil, and I will come to it, thought to be the first-line prophylactic agent, but the evidence for it is very limited, and I will touch on that. Now, whenever you talk about a treatment option or have gone through a treatment option, the practitioner wants to hear about two things. One, did it work? And if so, in what modality? What did you notice? Reduced number of attacks, reduced intensity, length of attacks, easier to treat attacks, and side effects, tolerability. So please, when you mention a treatment to a practitioner, mention both of these. So we're on the lookout, listening for both. For instance, if you said, oh, I can't take the sumatriptan, it just made me too dizzy. I'm just too dizzy. Well, did it get rid of your headache? Yeah, it got rid of my headache. Well, that's something to know. Maybe they'd respond to a lower dose of sumatriptan, wouldn't give them so much side effects, and would still get rid of the attack. So if a treatment option didn't work, it's out. If it did work, how do they tolerate it, and what can we do to reduce that? I often get asked, how do you talk about controversial topics with your doctor without getting thrown out? The first thing is just to ask them their opinion. And if it's very controversial and you don't even want to voice it, you could bring up some paperwork. And that's where review articles and opinion pieces, editorials in professional magazines and journals can be helpful, because then you could just show that you present a copy to the practitioner and say, I'd like your opinion on this. And if they blow a gasket, you know at least where they stand. And you can also mention that you've reached out to the advocacy organization looking for options. And I always say to everybody they should get Ashley Hattle's book on cluster headache. And that's another way of starting a conversation with a practitioner. I say practitioner, it could be a nurse practitioner, physician. And one of the reasons physicians appear to not want to talk about agents, which are so-called Schedule 1. Schedule 1 agents are agents which allegedly don't have any medical use and are not able to be prescribed. The classic agent was cannabis, marijuana in Schedule 1. And the reason I show this slide is to say the message that's in the editorial from the New England Journal, September 11, 2014, George Annis, is that courts have repeatedly come down on the side of physicians if they counsel patients on Schedule 1 agents. They just can't provide that Schedule 1 agent, but merely counseling them on medical issues, even if Schedule 1 is not a crime. And this was started to be brought about after medical marijuana was introduced in California in 1996. And as you heard briefly earlier, roughly speaking, if you have to think about whether your cluster headache treatment is working, it ain't working. And that applies to abortives and prophylactic agents, and they're very different. So, of course, the sumatriptan injection is not going to be prophylactic. And some say it even promotes attacks. I'm not sure that's the case. It may be for some, but not for most. And so therapeutic treatment options can be either abort the individual attack, Or prophylactic, reduce the intensity and frequency of attacks, or induce a remission ideally. And sometimes we use the term transitional, and that's when you're active to try and push you into remission, but you can't keep it going, or at least not ideally, like steroids, for instance. I often show this slide, which is dated now 5-6 years, the American Headache Society guidelines. So these are based on evidence and evidence-based medicine, not opinion, but evidence. We have the sumatriptan injection, the high-flow oxygen, and even the zolmitriptan. So if the injection sumatriptan and oxygen are by far the best, and that's, I see somebody has commented about can't take the triptans because they've had cardiac disease. That's right. If you do have bad vascular disease, cardiac disease, you really shouldn't be taking triptans. But for those who can, there's nothing better than injectable sumatriptan or high-flow oxygen. The next best thing is the nasal zolmitriptan, and that comes in 5 milligram nasal sprays. And we have evidence showing that either 5 or 10 milligrams, but as a practitioner, I cannot write 10 milligrams, otherwise the pharmacy is going to get into a tizzy over it because it's only indicated for 5 milligrams at a time. And up to recently, at least in the United States, the zolmitriptan Zomig nasal spray was brand only and extremely expensive, although it can be obtained from Canada for $3 a pop. Everything else is not as good. Oral agents are just too slow. So beware of a practitioner who firstly gives you oral medications for to abort an attack, because eventually you're going to realize that that is too slow, and some people get a little upset when they realize that they should have gone to high-flow oxygen or injectable sumatriptan first and not dancing around oral agents. All right. So high-flow oxygen been used for a long time, decades ago. A first systemic study of it, not against placebo, but a study, was Kudrow, 1981. And his son is a headache medicine practitioner in California right now. And his daughter was that actress in Friends, Lisa Kudrow. And fortunately, we have more evidence-based medicine. Cohen and Goldsby again demonstrated high-flow oxygen at 12 liters a minute, better than room air. The other study that was positive was only 6 liters. And these days, I advocate uniformly for 15 liters a minute. And non-rebreather mask, nasal cannula is not going to work. Okay, and yeah, I'm asked about, there is a question about a daily Imitrex, a daily sumatriptan and rebound.
Yes.
You know, it's not as it's not as common as with other agents. And by rebound, we mean it promotes the recurrence, not just the treatment wears off. So the thought is that if you use sumatriptan daily, you end up with more attacks. I don't believe that's clearly so, at least for the episodics. It may or may not be the case. In the same with migraine, the amount of use of abortives may or may not. And the only way you're going to know for certain is to stop it and see. But I wouldn't, I'm just trying to put the brakes on trying to tar sumatriptan as being a bad agent when it's not. And there are plenty of, certainly, patients with cluster using sumatriptan daily who are not in rebound. Generally speaking, the rebound mechanisms are more of a migrainous phenomena, not a cluster phenomena. And
thanks, Brian. I think the other questions that
Yep.
we had before, I'm just sort of scrolling back here.
Yep.
I think we covered the Zomig because of the cardiac issues. Someone else has asked, they've had a lot of preventative medication, as have most of us. verapamil, lithium, gabapentin, and so on and so forth. The only medication that worked for attacks was injectable sumatriptan and medical oxygen. And the question really is, why do physicians prescribe so many preventative medications?
Right. Yeah, it is not that they want to slow torture you.
Right.
It's not that. It's really, it's, you know, when you're a hammer, everything is a nail. It's the physicians we can feel somewhat inadequate when we can't do much for patients. And we have options that we use in other disorders, migraine, or in other disorders completely, the anti-seizure agents. And in desperation, we use what we have. So in some ways, it's like the drunk guy and the keys under the lamppost, but at least we are familiar with that area, with that landscape, the anti-seizure medication landscape. But we need to be a lot more familiar with your response and your tolerability. So it is, nothing's going to take away the trial and error. Unfortunately, that even in other spheres of headache medicine and in other parts of neurology and medicine, we don't know, there's a great variation in responsiveness, and we don't know without trying. So the reason there that you went on a lot is, as did many of you, is that they don't work that well for most people, and we're trying to see if we can get lucky. Unfortunately, that's what's going on.
Yeah, I think that's a very common situation for many, many people who've had to, as you say, Brian, trial and error. You know, you know what your patient's presenting with, and you have a starting point.
But the mistake is to be trial and erroring long shots when you haven't even tried the basics.
Right.
And really, I should make a slide of just the basics you all have to go through. And I will touch on verapamil shortly, but just to finish off with oxygen, there is a concern among some practitioners that we may cause oxygen toxicity, but that's really a phenomena in the ICU and intensive care and high pressure. It's not something you can develop in 20 minutes, giving yourself a 20, even 25-minute oxygen flow. It is true that in certain people with bad obstructive airways disease from, say, a lifetime of smoking, their respiratory drive may depend on oxygen. Well, it's their drive to breathe may change. It depends on the CO2 and oxygen, and you may suppress breathing. The worry is, and it can happen with supplemental oxygen, paradoxically, but that really happens over a long period of time, not short. So I've never heard a problem, even in people with lung disease, using extra oxygen temporarily. So the worry about oxygen toxicity is not really relevant to short administration. And don't forget, nice and hard. All right. Okay. We touched on the triptans, and we heard earlier about the vials, but the good thing about the vials is that you can use an insulin needle. Here's a one mil insulin needle that you can get, at least in the United States. You can get those online. You do not need a prescription to get the needles, and then draw up with the sumatriptan vials how much you feel you need, which is often less than 6 milligrams, often half, and sometimes even less than that. And the benefit of that is you can give yourself more injections. And the more than 90% of patients with cluster are going to respond well to injection sumatriptan. Occasionally, some people do need the full dose, which is 6 milligrams. Not everybody should be given triptans. Those with, again, vascular disease, heart disease, cerebrovascular disease, most of folks who've had strokes. There have been occasions I've agreed to prescribe in people who've had a stroke because it's due to a particular thing that was addressed. And Pregnancy is not a contraindication to triptans now, but it is a contraindication to ergots. For a long time, we avoided triptans in pregnancy. In my strong opinion, that no longer needs to be the case, and also the opinion of many others in the headache medicine community. To be used in moderation, of course. Transitional treatment, generally a blast of steroids, as most of us know, tends to help or eliminate temporarily. And there's recently been a good study, placebo-controlled study to evidence-based medicine for that. And I cut out an image from one of the forums on the left. I'm not going to read that out. You can read it out yourself. All right. I was asked about verapamil. And the trouble about verapamil, it is really the first line agent in prophylaxis. But it turns out we only have one small study that was positive, a randomized placebo-controlled study. And 8 of those subjects already had prior experience of verapamil, nearly all positive. Kind of biased the study. So we make a universal recommendation on what is a very small amount of evidence-based medicine. And for a fair number of people, it doesn't do a damn thing. But for a fair number, it can reduce the intensity, even a lot, of the attacks or frequency, or make the attacks at least responsive to other things. But you don't know without trying it. Now, I was asked about higher dose. I tend to, now, you'll read in the literature, in the professional literature, people using 120 milligrams a day, even 960. I get a bit slow in going up really high. In order to, it's my opinion that if you're going to go up really high, you should have a background of some response. So if you've got to 480, 560 milligrams a day and it does nothing, I don't think you're going to get a great benefit by going higher. But if you did or had at least temporarily a good response, that's another reason to go high. But what you need to worry about if you go high, it's not going to kill you. Now, constipation is a big deal when you get into higher dose. Concrete, yeah. And having cardiograms is a useful thing to have. Now, not because your heart is going to stop, it's not. But there is an emergency cardiac rhythm, which is occasionally you flip into, which is about 30 beats or 25 beats a minute. It's too low for you. So what will happen is you'll flip into 3rd degree heart block, that's the term, and you'll go to deck, you'll go to ground, you'll collapse. And then when you realize it was due to the verapamil, you'll probably have some expletives for the prescriber of the verapamil. But not to worry, as the verapamil wears off, the problem wears off and you're back to the way you were. And that is a rare thing. And it's really only at high doses when you would need cardiograms to see if you're at risk for that. And if you are, consider coming down or off it. And when I say, if you see level A evidence, suboccipital steroid injections, I do believe, well, that was only one study, a small study. It's great that it was done. And for a long time, that was the only placebo-controlled steroid study. And so there was no tablet placebo-controlled steroid study, but there is now. But again, small amount of evidence-based medicine. We heard about Emgality earlier. You need to know that there are 2 different doses of Emgality. One is for migraine, which is 120 a month. And it's 300 milligrams. So notice markedly different dose, much higher for cluster. So please don't allow yourself to be given the migraine dose. And it's only been shown to be of benefit in episodic. And it's a bit hit or miss. It's not, I mean, if you can get it, try it. It's not going to do anything bad to you. Really, the tolerability is tremendous. And hundreds of thousands of people have used this now in connection with migraine. And we have a lot of comfort over the use of it. And this would be monthly injection under the skin, no drug interactions, no dizziness, no drowsiness, no effect on the liver. So at least it's well tolerated. And there was a free program. I'm not sure. I don't think it's active currently. And the only other thing I'll say about it as well, if the patient is annoying you, can always say, inject it under the toenail, and that'll give them something to remember it by. I'm kidding.
Ouch.
Yep. They'll feel every micro mil that goes in.
For sure.
And Ashley's book, everybody needs to get. Remember, this is the book that will help your friends and family understand, and even your doctor. Because you can always open up the page and what do you think of this treatment, sort of thing. So it really everybody needs to have that. And I have no business relationship with that. I also showed this last year, the clinicaltrials.gov. You can go to www.clinicaltrials.gov and see all the cluster headache trials. A lot of them are registered on this site. This is a US federal government site, but there's a lot of international studies that are registered, because if they ever want to publish a clinical study, a lot of journals now demand that you have registered it beforehand. That's why it's done. And you can look up, and I just happen to, this happens to be a graphic from a trial using a coin-sized device that you put to your skin. They happen to have zolmitriptan on, and looking at that as an abortive. And my understanding is that what data we had was pretty encouraging. I'm not sure what the latest on that is. And patients, of course, have advocated for a long time. They've taught us how to use oxygen, even with a mouthpiece. This is Mr. Beebe, a longtime member of the Clusterbusters organization, using a mouthpiece. So you don't necessarily have to have the mask. Sometimes the mask, people feel a mask is almost too sore or uncomfortable. And I'm not going to advocate Welder's oxygen, but I will say that it's not mixed with anything that might be poisonous or detrimental. And we now have a number. Yes.
So sorry to interrupt you.
Sure.
Just while we're talking about oxygen there, I have a question.
Yes.
Would you mind taking? Thank you. Someone has asked, does hyperventilating work? Pretty much talking about hyperventilating as being a great vasoconstriction method. I just wondered what your thoughts were.
Well, I think what the person means is hyperventilating during oxygen treatment. But when you hyperventilate in room air, for instance, there is a certain amount of vasoconstriction of blood vessels that goes on. So some blood vessels do get narrower, but and you blow off a lot of CO2 that changes your pH a little bit, and you can get dizzy pretty quickly. I don't advocate that, and this is a brain disorder. It's not a blood vessel disorder. Yes, you may notice enlarged blood vessels during an attack, but it's a brain disorder. That's where the attack originates. That's where you feel the pain. So the effects on blood vessels are an epiphenomena. I don't feel that that's critical in the causative pathway. Remember, it's even been demonstrated that even cutting out the trigeminal, the main nerve, doesn't always stop cluster. You can still perceive pain, unfortunately, even if you don't have the nerves. It's a brain phenomena. Any other questions?
I have another question relating to psilocybin, which I would like to ask you. So someone has asked, is there any concern with valve issues? And I presume when this person says valve issues, they mean heart valve issues. I'm assuming for people that are using psilocybin, and very often, and very being in capital letters, i.e. multiple times per week. This person says it was an issue with other 5-HT2B agonist used daily. Just wondered what your opinion.
That's something I do mention, and it's a very that's a very good question, an important question to bring everybody on board. Those of you who are old enough will remember the fen-phen fiasco, a dietary medication for losing weight. This is over 25 years ago, and it was taken off the market after some patients developed cardiac valve issues. And it was really only after that that it was properly identified what serotonin receptor was being activated on cardiac valves, heart valves, to cause them to proliferate or thicken abnormally. And it's a subset of one of the serotonin receptors. There are about 15 receptors if you count the subsets, different ones. And this was also seen in conditions where you have too much serotonin running around the body. There are medical conditions. So cardiac valve abnormalities were seen from the 1950s, but we didn't know what receptors were responsible. And it turns out that that particular receptor is also tickled to some extent by the hallucinogens. And then the question would be, how much is it tickled, and when does it become a problem? And the answer is it's a longer answer, because there is evidence that you can tickle that receptor a certain amount and not get valve abnormalities, because there is a medication that's still on the market, carbergoline, which is a dopamine agonist, but it has a serotonin effect as well. And that, when used very frequently, results in cardiac abnormalities. But when it's used infrequently or once a week for certain indications, it doesn't appear to cause a problem. And that's powerful evidence that you can take a medication periodically and not run into trouble. But the trouble is, it's very difficult to gauge risk with psilocybin and LSD. It looks like LSD has more of an affinity for that problem receptor, but you're using it in microdoses, whereas you're using psilocybin in milligrams. So micrograms for LSD, milligrams for psilocybin. It looks like psilocybin is probably safer, but then you'd want to be taking it very frequently to be a problem. And then what are thresholds? And I don't have clear thresholds for you, but it's something I would worry about with the microdosing every other day use. I would be concerned about that, and it is yet to be determined. And if you were taking an awful lot, I would consider getting a cardiac echo, although you might have a fun time trying to explain why you want it. I mean, further, I can address that further on request and later on in the meeting. But it's not a concern for periodic use. I have up on the slide this non-invasive vagal nerve stimulation device. It does have an indication to abort an actual attack in episodic, not chronic. It's probably a lot weaker than what we have, because it doesn't abort attacks in chronic, and our current regimen, oxygen, sumatriptan, do. I think the effect is very, very modest, but I will tell you, it is completely safe. It's a little electrical tickle. It's completely safe. You do not have to worry about that. It's just, I question the usefulness, and I'm very open to hear anybody's experience with this. There was a trial, some of you will know, with implantation of a device into the midface, like a dental procedure, and it would tickle the sphenopalatine ganglion. The handheld device induced a current in the implanted device, so the implanted device didn't have a battery. However, during the study, the company essentially went bankrupt, and some people were left with these devices in their faces. Isn't that right? I'm sure there are one or two of you watching this right now, and I'd be curious to know what you did and whether you can get this out. Now, the data we had on it was interesting and somewhat positive. And I don't discount this in the future, and it may still exist in Europe in some form. Lithium has been an old standard trial. We really don't have good evidence-based medicine for it, so it's really more evidence, or it's opinion. It's what I would term eminence-based medicine, not evidence-based medicine. And if you do use lithium, you do have to subject yourself to occasional blood tests to make sure you don't swing over. If you swing over, you go batty. If you have a high lithium level, you tend to go a bit bonkers, unfortunately. Don't worry, it doesn't do anything permanent unless you do something permanent when you're batty, when you're toxic on it. Now, most people don't go toxic. Don't be too scared at that, as long as one is on top of it. And with smaller doses, it's easy to use. There can be a problem with, we generally have to avoid anti-inflammatories because it can elevate the level of lithium. I'm going to say a little bit about ketamine. If you go to the clinicaltrials.gov, and I encourage you to do that, and plug in cluster headache and ketamine, you'll see there are 2 or 3 studies there, and some of them are active, I think, but the recruiting active may be in Europe. Now, some of you know I've used this as a nasal spray for 10 years now for patients who have failed the more standard. It's not a first line, and some could say it's not even a second line, but it may be a component to a treatment regimen if you've failed other agents or get very frequent attacks. Give yourself a break from other treatment options as a nasal spray. There is a product, a branded product from psychiatry available now, but it costs thousands per month in the United States. So, and it will not be covered under insurance. For cluster headache, it won't. So it's really a non-starter. You can get a bottle from a compounding pharmacy for $100, and that'll do you a month anyway. You will see about infusions of ketamine, but that costs thousands. And now, a less than full description of the infusion will say, oh, the ketamine is very cheap. Yes, it is very cheap, but using an infusion center and the nurses and physicians involved in an infusion is expensive. So infusions cost thousands, maybe 1,000 or 2, whereas a compounded nasal spray ketamine, $100. And this is an anesthetic, and if you take enough of it, you'll go to sleep. But fortunately, generally speaking, you won't stop breathing, unlike with opioids. So it tends to be safer. In the United States, it's a Schedule 3, meaning I can prescribe it, and refills are allowed. I believe it's more heavily scheduled in Canada. And it's just been, I know for some folks, it's been very helpful when they failed other options. And my graphic on the bottom left is really because it's known as a horse tranquilizer as well. What can I say? But it's not intrinsically dangerous. Drugs are neither good nor bad. It's the use they're put to it. They're put that determines a goodness or badness, so to speak. Now, so it's really the ketamine nasal spray is in the literature for some years treating prolonged migraine aura. And I know I mentioned it nearly 10 years ago in a review article. I put it in there as something that could be used. But still, a lot of physicians run for the hills, and especially if a patient is going to request something like this, which is why bringing an article